Here we are. Happy September. Big shout out to September 11 and memorial to everybody who lost a life that day or lost a loved one that day. It always makes me reflect on how lucky we are to live in America, but freedom's not free. And just thinking where I was 20 years ago, right? And that my kids are, it's like ancient history for them. Like they won't know, they're not old enough now to have a conversation about 20 years after 9/11, but in 10 years they will, and it'll be like ancient history. Where for us, for me, this was a big turning point in America for us. So just thoughts to everybody on 9/11. On that note, live podcast recording, pretty excited. I am doing 2 this month. So the first one's today, which will be released on the podcast tomorrow. And then I'm going to do another one on the 23rd of September. Same thing, 1 p.m. Pacific Standard Time. I'm just logging on to see the 23rd. Yep. Because I didn't do it in August, and I made a commitment to do them monthly, and August just got away from me, summertime. So September is a lot more reasonable. So to the people that are here, we're going to do a couple of things. Number one, you can type in your questions, or if you want to come on live and do questions or do coaching or discuss a topic that we all know and love, female pelvic medicine and sex, we will. So until I see hands go up and volunteers, otherwise I'm just going to assume you're going to be live audience members who don't want to participate. I'm going to go through the questions. So most of these questions are coming from either typing in during the live Zoom recording webinar today, or questions that people have given me on Instagram kind of through the month, through the last 6 weeks actually, because I didn't do an August live. So I've written them all down and we will chat on them. What's it called? Disclaimer. Yeah. Disclaimer. I am a medical doctor. I am probably not your medical doctor. Even if I am, I shouldn't be giving you medical advice via a live podcast recording. So all of this is information. What do they say? For entertainment and educational purposes only. Consult your own physician. But what this does is it gives you guys the knowledge to then go back and like explore deeper. Does this apply to you? You know, all that stuff, and how to act as more of an equal when you're in that doctor-patient relationship. So point being, this isn't individual medical advice, but it might sound like it. It's just not. You're not paying me for that. Okay, so here we go. Hi, Dr. Kelly. I have a question. I'm not sure if it's all over the place, like meaning everywhere, but is there a back order on vaginal estrogen? I started my prescription last month. I'm so happy with the results. Thanks for all the great advice you give. I tried to refill my prescription and now there's none. I'm so disappointed. They offered me the pill to insert, but I know you really advise on cream, and I'm afraid if I use the insert pill, I won't get the same results. So I don't want to assume, but if this is not Canada, then it is a bigger problem. I've heard from another doctor in Canada that Canada now has a shortage. She actually texted me and she's like, are you the reason for the vaginal estrogen shortage in Canada right now? I don't think I'm that big yet, but maybe. So somewhere, I'm assuming Canada, there's no vaginal estrogen cream, which is ridiculous. This is a medication that's been around for 30 years, which is ridiculous that it's even like close to $100. This should be $4, you guys. This should cost the same amount as men pay for their Viagra and men pay for their prostate medications, because I would say it's equal. But yeah, so the rings are good. They tend to be expensive. I practice in America, so I know American prices. The ring tends to be pricey, but it's only once every 3 months, which is great for like plug and play for people. I don't like the tabs, mostly because I see people come and say that they still have genital urinary symptoms of menopause or pain with sex or recurrent UTIs. I just don't think the tab's enough. But I think in a pinch, so let's say you live somewhere where you can't get your vaginal estrogen cream right now, the tab's gonna at least give you some estrogen down there. So I would do that over none. So that would be my opinion. There was just an article on, is it an article when it's on the radio? An article on NPR about menopause and sex and dryness. And that doctor, I'm pretty sure it was a doctor, also recommended the cream, because she was saying how she liked how it got the labia and the structures. I think that 6 o'clock part on the labia really gets dry and irritated with menopause and dry skin and low estrogen. And so you can really take the cream and like localize it there. You can make sure the clitoris gets it. For all the people that are new here and don't understand why I like the cream better, I kind of like poo-poo I want to acknowledge, but I poo-poo the people who say the cream is too messy, because I'm like, do you remember what our vaginas did when we were in our 20s? Messy stuff down there. Like, that's what a normal healthy vagina is, right? We're just like used to this dry vagina when we've been on birth control or menopause. The other thing about it's too messy, make sure you're putting it up in the top of the vagina. Do it before you go to sleep. It should all be nice and soaked in before you wake up. The other thing about estrogen, I get this question all the time, is should I watch about making sure my male partner doesn't get it? And I joke around and I say, does a 30-year-old with a vagina worry about giving it to their partner? And they're like, no. So it's just don't put the cream on the penis. Like, don't put the cream on the male. But like, if you use it and then the next day, because you only use vaginal tabs or creams twice a week. I'm drinking a protein shake because I have kids and I haven't had lunch yet. I'm like the only podcaster who like drinks while she's podcasting. It's probably not good. Does Joe Rogan drink beverages while he podcasts? I'll do whatever that guy does. So that is that story about that. Somebody asked, the next question, somebody asked about the website screamforicecreamagain.com. So I had to look it up, screamforicecreamagain.com. First of all, you're using my metaphor, because my metaphor is you can't make me like melted ice cream. So, where are my royalty fees for that metaphor? But it's by Addie, which is a drug, which is FDA approved for female sexual desire. And so it really kind of sells, it's kind of like a sexy looking website. And it's really geared at younger women, because this FDA approved medication is actually not approved for postmenopausal women, which is ridiculous. They did studies, it works well. The FDA just made them separate menopause and postmenopausal women, which is ridiculous. So anyways, you'll see younger women on this website, which is not the only women in the world who have trouble with sex. So it really sells, I think, the idea of spontaneous desire being what is desired, what is the default, what we should all strive for. If you've been listening to me at all, you know that that's just one aspect of desire, and most women don't have spontaneous desire, they have responsive desire. And then my other argument is you don't even need desire. If you look at the like truly sexually happy older couples, they're not sitting around waiting for any sort of desire to happen. They just have good sex, meaning it's like going to the gym, you guys. Like, I don't always desire working out, but like when I'm doing it, I love it. When I'm done, I'm so glad I did it. Like, it's kind of like that. It's like working out's an important part of my life. Sex is, if it's an important part of your life and your relationship, you prioritize it. I believe in scheduling sex. So yeah, I think the drug is okay. It's not overwhelming in its success. If you look at the studies, some sexual medicine doctors really like it. I think there is a small subset of women. It works by affecting your neurotransmitters in your brain, helping you get more dopamine. Dopamine is the seeking neurotransmitter. Like, I'm seeking out my protein shake. Dopamine's like, do it, because you're going to be rewarded with the protein shake. So that's how that neurotransmitter works, is by increasing the levels of dopamine in the brain. I don't think that low dopamine is the reason that all women in this world have low desire. I think low desire, number one, is made up by society, because we've decided that the male desire level is the normal one, or the one to which all else should be matched, right? Because it's not good for women to have too high of a desire compared to their partner, and it's not good for a woman to have too low of a desire compared to her partner. Why is the woman always the problem? Drives me insane. So going back to the question, screamforicecreamagain.com, check it out, see what you think. You're gonna have trouble getting your insurance to cover this medication, because a lot of insurances don't cover sexual function, even Viagra, and all gender equality fairness. It's expensive. You have to take it every day. You have to take it for at least 3 to 4 weeks to know if it kicks in. And then you're taking a medication. So, which some people are fine with, but some people are like, are there other things you can do to have a great sex life besides take a pill every day? The data shows somewhere between it's like 1.3, I'm making it up, but it's a small amount of increased satisfying sexual events per month compared to placebo for these drugs for hypoactive sexual desire disorder. So you can see it. I'm a doctor. I prescribe things, and I'm a little poo-pooey about the meds. I'm not as raving about them as a lot of prescribers are. And I have to tell you, just the more I get into sex med, the psychologists, the PhDs, the therapists, kind of all the non-prescribing people are actually pretty turned off, pun intended, about making desire a medical issue for women, because they really believe it's a psychosocial, relationship, society, self-love, body image, all those other pieces, right? So if you take a pill, but you still have the thoughts, that's where the coaching comes in, that sex is a chore, it's just a to-do list, I'm unattractive, what is my partner thinking, what am I making his erection status mean, all of that stuff. Taking a pill doesn't help you. So it's wonderfully complex. I thought this website, screamforicecreamagain.com, it kind of turned me off. It was like very in your face, very like Hollywood glam. And I like didn't keep clicking. Plus I knew it was by Sprout Pharmaceuticals, which owns Phil Banserin. Okay, so let us keep moving on to the questions. Next question. Do you have a segment on localized estrogen to prevent UTIs? Yeah, I've got vaginal estrogen podcasts. Do I have a UTI podcast? I feel like I do. But this is what we know. A new paper just came out showing that in postmenopausal women, and I really loop in the perimenopausal women to this category, like our estrogen status is fluctuating. It's changing in everybody up to 10 years before the day of your last period. So perimenopause, menopause, recurrent UTI, adding vaginal estrogen decreases the risk of recurrent urinary tract infections by 68? It's in the 60s%, which is huge. There are very few meds, you guys, that improve somebody's condition by 68%. Like blockbuster drug. Clearly it's run out in Canada. They need to make more of it. I saw a study a while ago that like only 4% nowadays, this is like post Women's Health Initiative study, only 4% of perimenopausal women are on a vaginal estrogen product. And like the amount of suffering out there, there's probably 20 to 30% of postmenopausal women won't have any dryness or issues, but that leaves about 70% of them. And then only 4% of them are actually on vaginal estrogen, which means all these people are suffering. Is vaginal estrogen cream meant for menopause in general or more for more comfortable sex? All of the above. So I see a lot of, it's been 10 years with no vaginal estrogen and now this is going on in my pelvis. So as a doctor, I am kind of biased towards prevention, right? And then conversely, I'll see a 70-year-old who's been on vaginal estrogen and I'm doing a pelvic exam for whatever other reason, right? Not for genital urinary symptoms of menopause. 70-year-old, she's got like a 35-year-old vulva, which like beauty aside it's a very healthy looking vulva. Like your vulva doesn't have to age like it does when you take away the estrogen. So I think there's a preventative thing to it. I think Western medicine is very like get a disease and then we fix it. Western medicine isn't, let's try to keep you healthy and prevent disease in the first place, right? It's not the way we like to think. And I think convincing a woman who doesn't have the knowledge of like, how many vulvas have I looked at, right? But like to do something preventative wise, well, we do it. We wear sunscreen, we floss more than we have in the past when you just went to the dentist and got yelled at for your inflammation, right? We wear seatbelts. So we do we get colonoscopies, we get mammograms, right? So we do a lot of preventative health. Like and only to push back on the women who like bemoan the fact that they have to put estrogen in their vagina is like, we do tons of things we wear shoes so that our feet don't get beat up out on the streets, right? Like we do all these things to help prevent us from getting disease. And so I look at it like that. I think a myth that a lot of people have is that vaginal estrogen is for sexually active women. Yes, right? It drives me crazy because I'm like, why would you only want to take care of your vagina if there was like a man and a penis involved? Like, why wouldn't you want to take care of yourself regardless of that? Like bonus points if you're sexually active, it helps a healthy, happy sex life. And that's one of the ways I kind of encourage women to do it is like, oh, you are sexually active, let's maintain the softness of the skin, the lubrication, the moisture, the collagen. all of that. But I have a lot of women, they're like, oh, I didn't keep using that because I'm not sexually active. And I'm like, why would you be doing this for the man? This is for you. And all the reasons to do it besides being sexually active include decreased risk of yeast infections, decreased risk of urinary tract infections, decreased urgency, frequency, urinary leakage. I think there's a decrease in prolapse risk, but I haven't seen any study. I just know how healthy the skin looks. And I think when it doesn't get thinned, it's less likely to be stretched out. But somebody's gonna have to do that study so I can say decreased risk of prolapse. Let alone just the dryness and irritation and the burning that happens from dry skin, right? So I don't know, we put on lotion all the time so we don't have dry skin. This is just skincare. So I hope that helps. Thank you. My estrogen is below normal. My gyne hasn't offered anything, so I was curious about starting this. I think it should be preventative medicine. Again, my philosophy, and I think it's good for you to know because you can kind of go into your gynecologist this way and be like, I want to prevent disease. I want to stay healthy. I don't want to wait till I have painful, uncomfortable sex and tightness and UTIs to come in to get my vaginal estrogen, right? So we know it is stinking safe, you guys. Like it's such a safe product. It's so low dose. It's literally just skincare, right? It's like I put sunscreen on my forehead and my elbow can still get burned because it's like too low a dose and it's just here. So it's very, very localized stuff. I would think we haven't been trained. Me speaking for the doctors, we haven't been trained in like preventative menopause care at this point. I think we were before the Women's Health Initiative came out and ripped everybody off of their hormones in 2002. Over 70% of postmenopausal women were on estrogen, you guys, in the 80s and 90s. That went away. And then what happened is all the newer doctors didn't get trained in it. We kind of got taught that vaginal estrogen is bad. So that's my long-winded answer of like, you're in perimenopause. The other thing about general urinary symptoms of menopause, so pelvic issues of menopause, where we're talking about using specifically vaginal estrogen, is it takes a while for it to happen. So it's kind of like skincare on your face. Like that sun damage that you got when you were 18, like you're going to start seeing it when you're later, right? You don't really see it when you're 18. So like if you're 52 and you've been through menopause, you might not have issues with a dry, painful vagina and vulva yet. Like it's the gift that keeps on giving. And I think it just to speak to like the lack of menopause education, so many women in their late 60s or whatever, they're like, oh, I'm over menopause. I'm like, there's no over menopause. Like you're postmenopausal, meaning like menopause, the definition's like that day where you haven't had a period in a year, like technically that's your menopause. But like you're not over it, like it's not a problem anymore. And I think a lot of people think like, I had hot flashes and then my hot flashes got better. Average length of hot flashes, you guys, is 7 to 10 years. It can be a very long time for people. But when that ends, the vulva and vagina still will progress. It's a progressive disease. So many people just think like, oh, I'm over it. I'm like, no, it's kicking in. So the preventative medicine for vaginal estrogen, definitely by age 60. I would say, because it really starts kicking in like late 50s, I think. So I hope that was helpful. That was a long story about estrogen to prevent UTIs, but there you go. Okay, next. Hi there, I follow you. I really like your view and attitude in an area that's just not talked about. Totally, thank you. I'm menopausal, mid-50s, no libido, sex is painful due to dryness, and I don't want to go on hormone replacement therapy. Why? I have a couple of bad experiences with specialist menopause clinics, so I'm scared to reach out again. Wonder what that's about. Your recent post about vaginal estrogen sounds like something I might need. Do you have any recommendations in the UK? No, and you've already been to specialist menopause clinics. Oh, what is happening? I am not a doctor in the UK. I would think you don't have to go to, because in America, which I'm more comfortable talking about, in America, you don't have to go to a gynecologist or a urologist to get vaginal estrogen. Like any primary care doctor, internal medicine doctor, family medicine doctor can prescribe that. You don't have to, you don't need any specialist training to do that. And if you're thinking you're just wanting to do vaginal estrogen, then I would just go to your GP and start there. Certainly you're not going to have a libido if you have painful sex. That's always number one. There's so much to unpack in this paragraph. I really appreciate the woman who wrote this in. You won't have any sex drive as long as you're having dry, painful vagina, stereotypically, because we don't desire things that hurt us, right? It's more of an avoidance pattern at that time. You want to avoid things that hurt you. So the vaginal estrogen can help the dryness. It can help the pain with sex, especially if it's tight skin. That 6 o'clock position is like at the bottom of the vulva is really, really the tough spot for I think a lot of people, as far as dryness and pain. So my question would be that libido, again, we got to fix the pain to get to the libido. Sometimes libido is hormones. Sometimes some people are libido responsive, but then I always like to say, and remember, you don't need a libido to enjoy sex, but we got to work out that pain and desire, and what sex means to you, right? And then you tend to see that libido come back. Because a lot of people when they say libido, what they mean is a spontaneous sex drive, and we know that goes away normally in monogamous long-term relationships. So don't expect to have something that we know just goes away, except for some people. Some people are unicorns and they're like always desiring their spouse. But I think a big part of that, you guys, is their mind. Like they're choosing that their spouse still turns them on. They see the good in that person. They see how they can still consider them sexy. They still think they're the most beautiful person. Like there's so much work that goes into your desire of the person you're sleeping with, and it's not to be downplayed. I think it is downplayed when we start talking about medications being the answer or hormones being the answer. Those aren't the answer for everybody. And there are plenty of people, there's plenty of people who are post-menopause, not on hormone replacement therapy, having wonderful sex life. They might be on a little vaginal estrogen, but again, that's not considered technically hormone therapy. So I hope that was helpful for you. Next, can local estrogen fix a urethral carbuncle? Such a good question. So a urethral carbuncle, other words for urethral carbuncle are urethral prolapse. Think of it kind of like, this is how I tell people. I get this consult in my clinic all the time. It'll either bleed when they wipe, or it can be painful, but it's pretty rare that it's painful, or usually just like a GP or a gynecologist notices it on an exam and they don't know what it is, so they send it to me, and then I say, oh, you're postmenopausal and you're not on vaginal estrogen cream. Here you go. So think of it like this. Think of your cheek, and think of your cheek popping out, right? So the inside pinky wet lining of your cheek is now sticking outside of your mouth. That is what a urethral carbuncle is, or urethral prolapse is. Why this is happening is a weakness or thinning of the tissues because of lack of estrogen. So for people who can see me, because I'm going to post this on YouTube, I still have like my cheek sticking out. So what you do is you put estrogen cream on there. That's again why I like the cream. You can't fix it with a tab, right? You put the cream right on there. I always say put the cream in the vagina, then put a little extra on the urethral prolapse and vulva, and it'll recede or normalize with time. And you're going to want to, I usually recheck people at about 3 months time to make sure it's better. If it's bleeding or if it's painful, sometimes it can be kind of thrombosed or sore, kind of like a thrombosed hemorrhoid. That's pretty rare. I've done surgery on these, 2 or 3 times. It's pretty rare, you guys. Estrogen cream fixes it. But then going into, should I be on vaginal estrogen cream preventatively, right? Like, look at that woman. That woman has a bleeding urethra or a carbuncle, and now we've got to treat the disease instead of preventing it in the first place. So I didn't even bring up urethral prolapse in a reason to not be on, or to be on vaginal estrogen. So yes, 100% can local estrogen fix a urethral carbuncle. If anybody has a mass down there and you don't know what it is, go get it checked out by somebody who knows what they're doing when they look down there. But urethral prolapse is incredibly common. Just people don't know what it is. They don't know that it is a normal? postmenopausal thing, common postmenopausal thing. Okay, next. A thought on where your function level should be for testosterone and estrogen. Curious. I have highs and lows and levels are fine. Let's see. So the question is, where should your testosterone and estrogen be? Maybe. Depends on what your goals are. There's plenty of people post-menopause who don't take hormone replacement therapy. So your testosterone should be low, your estrogen should be low. So as far as normal goes, the menopause experts really go towards quality of life and how you're feeling more than just trying to aim for a certain level. Doctors don't really like, most doctors don't really like to chase numbers. As far as that goes, it's like, if you're feeling good, are you sleeping? Are your hot flashes better? Is your sex drive where you want it to be? And you've worked on all the other psychosocial issues, then you're probably at a good dose of estrogen and testosterone. The guidelines say as low a dose as possible to meet your clinical, goals if you're feeling well. If you're on an estrogen dose and you're still having hot flashes and night sweats, it's probably too low, right? But I wouldn't check levels to find that out. I would just talk to the woman and be like, her estrogen is probably too low because she's still having symptoms of low estrogen. So I think that's how I would answer that question without any further information on it. Okay, next one. Kelly, thanks for everything you've done to educate people on women's health. I've learned so much, and so has my husband. Yay, I love it when couples listen to this podcast together. Like, shout out to all the couples who are listening together right now and give each other a big high five. You guys rule. You've relieved a lot of anxiety, I'm sure, around sexual health. I recommend your podcast to everyone. That said, I'm a busy mom of lots of children, God bless you, and a business owner. And I've heard you talk lots about vaginal estrogen for hormone replacement. What are your thoughts on birth control pill over 40? I like it for the regularity of periods and to control acne. I do find it depletes my libido. But does it keep my hormones regulated to help what I assume is perimenopausal symptoms? Any insight you could provide would be great. Thanks. Great question. Okay, so the question, to summarize, to pull the question out of there, with a woman in her over 40s, we're going to assume she's in her early 40s. So these people can still get pregnant unless you have a vasectomy in your life or something like that, or you've had a hysterectomy, right? So everybody's situation is unique, but you still want to provide birth control if she's not using anything else like a hysterectomy or a vasectomy or a same-sex couple, whatever. Lots of different reasons that you could still get pregnant if you're playing around with sperm. Maybe that's how I should say it. If you're playing around with sperm in your early 40s, you can still get pregnant. So some people will use birth control pills because what it does is it mellows out, not mellows out, it's the wrong word, but like perimenopause is a roller coaster, right? Like estrogen's up, estrogen's down. I'm trying to release an egg. I don't have any estrogen at all. So it's a roller coaster, and that's where the symptoms come from. So what birth control pill does is it kind of mellows that out, like flatlines it, just to give you some steady state, which is very good for like mood stabilization, helping you sleep, helping the early signs of menopause. Every time there's a big pause, I took a big swig of my shake. So I really like that. It's an option. Birth control is an option. The other option, if you still need protection against sperm protection, should we say that, is an IUD, because an IUD can, a progesterone specific IUD, not the copper IUD. So the progesterone specific IUD protects the uterine lining, and then you can start on low dose hormone replacement therapy. So the new term for hormone replacement therapy is just hormone therapy. So you've got your progesterone IUD, and now you've got your estrogen patch. Estrogen patch, so systemic estrogen delivered in patch form, is about as damn safe as you can make hormones. It's safer than birth control pills, you guys. Oral birth control pills, because it goes through your liver, risk of blood clots, right? And then the other thing is, as far as that sex drive goes, because so many women notice a decrease in your sex drive on oral birth control pill, is it goes to your liver. It makes your liver produce sex hormone binding globulin, and that latches onto your testosterone and estrogen, kind of acts as like a blocker in just a simple way to describe that, but it makes it not free to be active. So a lot of women will notice a flat line in their libido on oral birth control pill. Get off of that, go onto the patch. The patch has less side effects, sexual side effects, than an oral because it doesn't have that first pass metabolism through the liver. So a lot of people will notice their libido is a lot better when they're on the patch, and then you do the progesterone through the IUD for the birth control and protection of the uterus. I think, so IUDs aren't FDA approved for menopause, but I think for menopause practitioners in the know, putting a woman on systemic patch estrogen and an IUD is kind of becoming a great option. I would say trendy, but like it's for people who know what they're doing. Because if there's any danger, some people think, if there's any danger in hormone therapy causing breast cancer, it was the progesterone arm, which was medroxyprogesterone in oral form. So if you say, well, I don't want the breast cancer risk of hormone replacement therapy, great, get off the birth control because there's a little bit of risk with that too. Get off the oral progesterone, protect your uterus with an IUD. So I am throwing a whole bunch at you guys. Sorry for any beginners out there. But the more you hear this, the more you'll start understanding all the differences between it. I'm on estradiol and progesterone, vaginal estrogen, and compounded testosterone cream. I feel great, and if this is safe, I will never get off. God bless you. Preach it, buy a billboard, put it up in downtown, tell all your sisters. Like, this is what I'm talking about. When you get a woman who is feeling good in her life and she's got it figured out, like, she's got like decades to rock, you guys. You don't have to ever stop any of that. As long as you feel good and you're thriving, there's no time limit on it. And these people feel great. Like, I don't know if you guys see this, but how many women are so freaking miserable in menopause? And you don't have to be that way. And I'm telling you, the women who made it through the culling of the hormones in the early 2000s, like I have 80-year-olds that I see who are on estrogen. They look fantastic. They're loving life. They're doing their thing. And I'm like, if only people knew how vital and energetic and healthy these women are. Besides the fact you're protecting your bones from osteoporosis, more women will break a hip or an arm or a leg from falling in osteoporosis than the number of like heart attacks and breast cancer combined in this country. Like osteoporosis is, and that's what makes you end up in a nursing home and like bedbound. And it's just, it's a horrible quality of life. And this is because of you. I took your advice to my gyno and he said, you're so well informed. Oh my God, you guys. You're totally making my day. I'll keep doing this then. Yeah, there's nothing more awesome than like a well-informed person in clinic too, because like you just like there's a language ability to speak. Like you don't have to explain estrogen doesn't cause breast cancer. You don't have to explain like, yes, this goes in your vagina and it's not just for sex. Like all that stuff. It's like when a woman already knows all that stuff, she knows what she wants. She knows like the risks and benefits. What they do say as far as like, can I be on this forever? Is as we age, our risk for strokes, for heart disease, for cancer, it always continues to go up. And so they say like, if there's at some point where like your risk of something is so great that you should think of coming off of your hormones, that's a discussion you have with your doctor. I think many, many women in their 70s don't have much more risk factors. They love being on hormones. They're starting to, the other thing is they're starting to see their friends who didn't start on hormones, and they're starting to see the difference between the two of them as far as like vitality and health. But we definitely know, so point being, as you get older, our risk for everything, our risk for death, right? Like the risk for everything goes up. But as long as you keep having that conversation of like risks and benefits, yep, I'm staying healthy, I'm getting my mammograms, I'm still exercising, I'm eating right, I'm staying a normal weight. Like you're optimizing all of your health things to keep your risks as low as possible. Stay on your hormones, like rock on. What was my other thought with that? Oh, what we do know is for the younger menopause women, so women between the ages of 50 and 60, that being on hormones, they live longer, they have less colorectal cancer, they have less depression and anxiety, they have less risk of developing neurodegenerative diseases. I actually have an article, I have it here, so for people who can actually watch this on YouTube, I've been meaning to do a podcast on this, just because it's on my desk. Association between menopausal hormone therapy and risk of neurodegenerative diseases, implications for precision hormone therapy. So what this basically says was hormone therapy was associated with reduced risks of all neurodegenerative diseases. And what they looked at was Alzheimer's, Parkinson's, dementia, multiple sclerosis, amyotrophic lateral sclerosis, or Lou Gehrig's disease. So all of those, hormone therapy was associated with reduced risk of developing every single one of those disorders, including Alzheimer's disease and dementia, with greater duration of therapy associated with greater efficacy. So there you go. And we're protecting our brains. So yeah, educate yourself. Go see. And the other thing, just for the beginners in the room, is once you're 10 years past age of menopause, it's not recommended that you start hormones. So you don't need to rush into your doctor to get on them tomorrow, but like at some point your risks of heart disease is now too great to be protected by those hormones. It's too risky to throw a woman on hormones who hasn't been on hormones. So it's not recommended anymore. So within the next decade, rush on into your doctor and ask if hormones are right for you. Okay, so that was the best thing. We should just end on that level. I'll do like 2 more, because we are going to come back later in September. Do you know anyone highly qualified in Atlanta to deal with menopause? Atlanta. Not off the top of my head, but you want to check the North American Menopause Society. I think it's menopause.org to find a NAM certified practitioner. Is probably going to be, within Atlanta's huge. You should be able to find somebody. 55-year-old business owner, into fitness, dealing with menopause for 8 years. I can't sleep, belly fat, weight gain. I cannot shake. Yes, you guys, that is hormone mediated. It is that like below the belly button, little soft area, which we could decide to love. It is all of our thoughts, I know, but it's annoying for some people, possibly myself included. Hormone mediated. If you guys haven't checked out the Galveston Diet, it's an OB-GYN. She is very into diet post-menopause. She's also very pro hormone therapy. And she talks all the time about that little area of weight gain below the belly button, which is very kind of menopause mediated. In post-menopause, when people don't take estrogen, you start seeing an increase in the fat distribution down there. You also start to see decreased muscle. We lose our muscle as we age, right? Hormone supplementation, specifically testosterone, can help that, although not FDA approved for it. But yeah, I would say if you're 55, 8 years out, you're the one who get in before it's been 10 years, or they might not give it to you. So that said, 55 is still pretty darn young. Levels are, so to continue the question, I cried to my gyne and she put me on estrogen cream and Prozac. Okay, so I don't know if that estrogen cream is vaginal or systemic. Hopefully systemic, and then hopefully you don't have a uterus, because you need to protect your uterus when you're taking systemic estrogen. So the Prozac doesn't make me feel good, so I want to go off of it, need help. I want to feel like myself again. Yeah, you should feel like yourself. Like, to you, you've got a life to live. You own a business, you're into fitness, like you need to sleep, all that stuff. So I would focus on, so many women got put on antidepressants and anti-anxiety meds because we were so afraid of using hormones for so long. We've been able to get women off of their anti-anxiety meds and antidepressant meds by treating their menopause symptoms. A symptom of menopause is worsening mood, anxiety, depression. Certainly poor sleep in and of itself is enough to mess with your mood. So it is multifactorial. But I would say you're in Atlanta, you've got a huge medical system there. Find somebody to treat your menopause symptoms. And I can't give you personal medical advice, but I would be like, treat the menopause. Then the Prozac probably is not necessary. I mean, you've got like hot flashes and you can't sleep. Let's treat that. You might feel good enough to not be on Prozac. So I hope that that's helpful. Okay, let's do one more. I have to start by saying I love everything you do. I've learned so much. Man, you guys, this is so great. I have a question. I'm in my mid-40s. I saw my physician for typical perimenopause symptoms. I just recently got off the pill and had blood work done to see where my levels are. She's recommending that I need testosterone due to my low levels. I'm impressed. Forward-thinking physician you have. What's your opinion on this? So what you have to do, so people aren't going to like me for being so direct sometimes. They're like, oh, what could be recommended is you check your total testosterone and you check your sex hormone binding globulin. So remember back when I said what birth control does to sex hormone binding globulin, right? So this woman actually gave me her sex hormone binding globulin, which is pretty high. It was 229. And that isn't too surprising given the fact she was on birth control, right? So if you're on birth control, it can elevate your sex hormone binding globulin. It can keep it elevated. I haven't seen any study to say how long it can keep it elevated for. But so not surprised, she has a high sex hormone binding globulin and her testosterone was low. And then you can literally Google free testosterone calculator and you type in your sex hormone binding globulin and your total testosterone. The goal number based upon ISHWISH, International Society for the Study of Women's Sexual Health, is 0.6 to 0.8. So hers was 0.02. So double check me on that. In my brain now, I think it's 0.6 to 0.8, not 0.06. But regardless, hers is low. So I would say this, you can always start on testosterone. Remember, the experts don't recommend pellets. Pellets are super therapeutic. It's basically giving you a big steroid rush, which then you kind of get like dependent on. I don't want to say addicted to, but like life is good when you're high on steroids. It's super therapeutic. So what people do is they give you a topical cream product. It's a male product because there aren't any FDA approved women's testosterone products, and you dose it to the female dose. Just try it for like 3 months and then see how you feel. You can check your levels again. If you don't like it, stop. If you have side effects, stop. The thing I think of testosterone as like, if you're going to be on hormones, you're going to be on them for a very long time. And if you're going to a place that's charging you an arm and a leg for pellets and repeat labs over and over and over again, financially, I think number one, it's just not sustainable for a lot of people. Like, what's your goal? Is your goal thousands of dollars in cash-based hormones for the rest of your life? So I would just, again, be careful about who you're choosing to get this from, because I think from a long-term stability, it's like, why don't you pay like pennies on the dollar for FDA approved testosterone that you can dose to you, not women's FDA approved testosterone, but a male FDA approved testosterone dose that then you take at female doses. So I hope that was super helpful. So you guys, this was so great. I will record this up and put it out for distribution tomorrow for all the people who typed in questions and I didn't get to. So if I said, a lot of these were from Instagram, if I said I was doing it on today's podcast and you didn't see your question answered, tune in next time, September 23rd, 1 p.m. And I'll get to the rest of the questions and everything that's come in since then. In the meantime, you guys, I love you so much. Thank you for showing up. Thank you for sharing your stories. And remember, you are not broken. Love you.